I'm happy to welcome Dr. Von Hofe joining us tonight as a guest expert who's going to be talking all about genetic testing. This I know is a very important topic for clients of mine. For anyone who's catching us on the replay, if you register, you will be notified for all future workshops so that you don't miss it, and you can join us for the support group at the end. I'm Kristin, or Kiki, and I'm an infertility coach, and I help you reduce your stress and anxiety and fears and actually enjoy the journey and love your life while you're going through infertility treatments. And this is a workshop that we're doing every month to provide a free space to learn and connect. So I'm so glad you're here. And tonight we're talking about genetic testing, and the guest expert for tonight is Dr. Von Hofe, who works at Fertility Center of the Carolinas. And I actually know her personally because she is one of the doctors who worked on the team at UAB that helped me become a mother through IVF. So we not only have a professional connection, but she is part of my family storybook as one of the people responsible for making me a mom. So I'm really glad to give anybody here who does not know her the opportunity to know how awesome she is, how she's as smart as she is kind. And so, Dr. Von Hofe, I'm so glad you're here. Thank you for joining us tonight and sharing your wisdom on genetic testing.
Thanks so much for having me, Kristin, and good to see some familiar names and to meet new people. Really excited to be here. A little nervous, honestly, like I've never been the presenter of this type of setting, but happy to talk with each of you about this really important topic. Hope I'm going to teach you something that you didn't know. Hope that I can answer questions. Very important that I say I am not your individual doctor, and so I'm just here to provide information, but not really medical like advice specific to you. So, I want to be helpful, but I don't want you to leave with like concerns or questions about your care. Just maybe more information and be better prepared to have the important conversations that you are already going to have with your treatment team. To address the personal side of this, it's hard to do that without like getting a little bit teary, but I think that there is nothing more special than seeing success after ups and downs with a patient that you take care of, and that Kristin and I have continued this relationship and have now sort of taken it to this special space is just, it's kind of amazing. I think it's like super rare and really fun. So happy to be here. If you don't have your sheets, grab them, or at least grab something to jot down notes, because I think this topic is a little hard. Like it's not, it's pretty scientific. And so I'll try to kind of break it down into tangible, digestible pieces, and then please ask questions, type them in, and let me know if I'm not making sense or I'm not being clear. So the goal of tonight is to really help you understand what PGT is. What does it stand for? Who should consider it? And then what it does and doesn't do for you. It's not right for everybody. It's not something everybody needs to do, as evidenced by that beautiful baby that we just saw during the intro, to get a healthy pregnancy. So I just want to kind of do some myth busters and some general education, and then answer questions that you have. So I'm going to start with just some general education about what PGT is. So I think the background here that's interesting is like just IVF and fertility care in general has changed tremendously in the last 5 and 10, 15 years. And there's this sense of like everybody who does IVF gets twins or triplets or like octomom or, what happened. And so there's been a huge push in the fertility community now that we're really getting better and better at doing IVF to make sure that our IVF patients are having really safe pregnancies. And so the background is kind of like we figured out we could get genetic information about embryos that might make each single embryo a more viable pregnancy, and then we could reduce the number of embryos that we are transferring and improve pregnancy outcomes and reduce risk to moms. So that's sort of where this started, interestingly. And then we've been on a roller coaster, certainly through my fellowship training and even in the last year or two, about what it means. So PGT. So You go through an IVF cycle, you have your eggs retrieved, they're fertilized. The day after your egg retrieval is sort of day 1, and then your embryos generally get watched until sort of the day 5 to 6 range, and at that point it's called a blastocyst, and this is probably a term you've heard or thought about. At that blastocyst stage, you can actually, that has grown into about a 100 cell organism. So egg is 1 cell, sperm is 1 cell, they get together and then they grow and divide over the next 5 days. And at that sort of 100, 200 cell stage, you can actually take some of the cells off of the rim of the embryo where the placenta would develop. So not the part of the embryo that becomes the actual baby. And you can biopsy 5, 8, 10 cells and send those to a genetics lab to get looked at. The next step in that process is sort of like, okay, how are they looked at? What type of technology are we using to make sure that we're testing the embryo appropriately? And that's been all over the map too. So just there's next gen sequencing, there's CGH, there's SNP, there's microwave, there's all of these terms that are really hard to digest, and different tests are better for different patients. Typically, I feel like most clinics have moved to next gen sequencing, and so that's probably what you're looking at. But important to ask that question: what is the actual test that will happen to my 5, 8, 10 cells of my embryo? The information on the actual biopsy, so patients ask all the time, like, does that hurt my embryo? And the data really suggests no. Embryos are just, they're sort of these amazing multipotent organisms, and they can continue to grow and divide, and we don't see any real disruption in pregnancy rates or reproductive potential from biopsied embryos. So that's also important to know. We're not harming your embryo if we're talking to you about genetic testing. The other really important thing to know right off the bat is that if you're doing genetic testing for your embryo, that pretty much takes off the table the opportunity to do a fresh embryo transfer. So different clinics are doing fresh and frozen embryo transfers for different reasons, but you should know that if you're going to do genetic testing, it means your embryo is being biopsied and frozen, and then there's a delay while the genetics happen, and it's usually around 10 to 15 days. And so there's no opportunity to transfer that embryo in real time. You must freeze the embryo generally and come back and do a transfer later. So I think those are the basics of sort of what is PGT. The next thing to talk about is like, what are the letters after the hyphen? Why are there so many? And so when I was a first year fellow, it was like PGS and PGD, and then we switched to PGT and we started hyphenating things. And so let me walk you through those. So the most common PGT testing that is done is PGTA, and that stands for Pre-Implantation Genetic Testing for Aneuploidy. And that is actually doing a chromosomal analysis of the 5, 8, 10 cells that the lab gets and saying, what are the chromosomes that are here? We are supposed to be 46 chromosome organisms with an X and a Y or 2 X's. And that is like, do we see 46 chromosomes? Are there 2 X's? Are there an X and a Y? Are there pieces of chromosomes missing? Does anything look like it's in the wrong place? So the PGTA is just chromosome data. So if you're looking at your little cheat sheet and you're like, what does it not tell you? So the secret there is like, it really just tells you chromosomal data. It doesn't tell you whether your baby is going to have blue eyes or be tall or do well on the SAT or play basketball. Or like, seriously, it doesn't tell you whether you're going to have a baby with a heart defect. It doesn't tell you if you're going to have a baby that has 6 fingers on one hand. So there are like large pieces of data that we do not get from PGT. We really get chromosomal data. The M, if I move on from A, so the PGT-M is looking for a monogenetic disorder or somebody who is a carrier of some known gene mutation, which means mom or dad or mom and dad together are at risk of passing on something to a child that puts that child at risk of either not becoming a live birth baby or having some heritable genetic condition later in life. So examples of that, I'll give a personal example. My dad was a BRCA mutation carrier. And so while I was waiting for my BRCA mutation status, I was planning my PGTM of my baby. Like, okay, if I'm a BRCA mutation carrier, I can at least make sure that I am going to transfer an embryo that isn't at risk for breast cancer or ovarian cancer. So that is kind of that framework. Other things that might come across our desk as reproductive endocrinologists for PGTM are like cystic fibrosis, sickle cell disease, something that is either X-linked and passed on to only male embryos, or that mom and dad are both carriers for and could be passed on to like 25% of their offspring. So that's the M part. That's pretty specific. I will say sometimes we discover that patients are carriers for things that they weren't really thinking about by doing the carrier screening that you may or may not have talked about with your doctor at some point. That's like a panel of 200 things, and you check female partner and male partner or donor for those things and see if they both are carriers for that. That's the M. Okay, and then the last one, which is the least common, is PGTSR, and that means structural rearrangement. So that means in a mom or a dad, they have all of the right genes themselves, functional human, walking around, but maybe part of chromosome 15 is on chromosome 14 and vice versa. So he or she has all of the stuff and can be a functional person, but because of the way our chromosomes divide when we fertilize and grow cells, we're passing on an extra copy or fewer copies than are needed for a child. So a little bit complicated. That usually comes up for patients who have a history of recurrent pregnancy loss and have had specific testing of parental chromosomes, mom or dad, to see if there's an issue with a structural rearrangement in the parent. All right, so what does PGT do for you? That's a hard question. The honest answer is it really depends on who you are. So let me just talk about the data that we have. I think it's important to understand what we do know about it and then what we don't know about it. So if you are a woman of advanced reproductive age, which sadly is 35 years old, which I feel like is very young. If you fit into that category, we know that there are some increased risks of chromosomal abnormalities that sort of start creeping up in your actually early 30s, maybe 33, 34. But by 35, we have sort of labeled women as being advanced reproductive age because we feel like the prevalence of chromosomal abnormalities in the pregnancies of those women is at sort of a tipping point where we are concerned. So for women in that category, 35 plus and certainly, 37 plus, we see that it helps us pick which embryos to transfer. So I think this is a really nice point to sort of pause and say, there is so much that we learn about embryos. Look at my cutie. Hi. There's so much that we learn about embryos under the microscope. So how do they look? And that's what our embryologists tell us. They give our embryos grades. So these poor nuggets, before they're even transferred, are getting like grade 1, 2, and 3, or A's and B's and C's. And that is all sort of morphologic grading of embryos. It is important to understand the genetic piece of what embryos look like, so do they have normal chromosomes or not, is not necessarily aligned with the grading of the embryo that the lab gives. And so you can have genetically normal embryos that don't look great under the microscope, and you can have beautiful grade 1 embryos under the microscope that are not genetically normal. So that's like a caveat. Interestingly, and hear this, PGT does not change your chance of pregnancy overall. So I feel like that's hard to digest. What it changes is your time to pregnancy, and if you're in sort of the category of patients who we recommend PGT for, it could decrease your risk of miscarriage. So let me just, I'm mostly talking about PGTA because I think that's the most applicable. And I'm happy to answer specific questions about the other, but PGTA, if you're a 25-year-old who has an 80% chance that every embryo is normal, you can imagine, like, we don't need the genetics to have a chromosomally normal embryo if we pick one at random from the pile. That is obviously not true in women who are 37, 38, 40. Because the risk of chromosomal abnormality in an embryo at that point has gone up so substantially that if I'm picking at random based on how the embryo looks under the microscope, I might pick one that looks pretty but is genetically abnormal. So it reduces risk of miscarriage in a special population of patients. It increases chance of implantation in women who are over 35. But if you're over 35, it does not increase your chance of getting a positive pregnancy test. Okay, so you might get a positive beta. Now, the likelihood that you have a miscarriage might be slightly higher, and that would certainly be true for women who are over 35. But it doesn't change your chance overall for all comers of getting a positive pregnancy test at some point. Of course, that's not what patients care about, right? Patients care about bringing a baby home. And so I think the best way to think about PGTA in particular is, does it increase my chance of live birth? And the answer is yes, it increases your chance of delivery per embryo transfer. So every time I'm putting a tested embryo in, you are at a higher chance of bringing a baby home from the hospital than you would be if it was an untested embryo. Okay. So I mentioned some things that genetic testing doesn't tell you, and I just want to sort of retouch on those. It doesn't really tell you anything about the performance of your child after birth. It doesn't tell you anything about the potential complication of a pregnancy. Like, am I going to get gestational diabetes? Am I going to have preeclampsia? Do I need a C-section? Any of that stuff. It's just genetics. A huge thing that I should say, which I feel like is the elephant in the room every time I'm talking about genetics, is it also gives you gender, right? So that is important. And some patients want to know that, and some patients want no part of that. And there are clinics that do what's called family balancing, that is just basically, I've had 3 boys and we would like to have a girl. And that's a reason that you can do IVF. And some clinics don't do that, but you get gender information and you can know that as a patient if you want, or you can have it put in an envelope and find out later, or you can be like everybody else and find out, at 14 weeks or 20 weeks. So that information is available to us and comes in the report. Important to know. How good is the genetic testing? So it's important, if you're going to do this test that costs money and makes things complicated, that you can trust it. And it's, I think, paramount that I say that this genetic testing is a screening test. So it is not diagnostic. Remember when I described what it was, if you think of this beautiful embryo and you're taking some cells from the periphery, your data is only as good as the cells that you took off. So what does that mean? Embryos, because they are so resilient, they actually can repair themselves sometimes. They can fix problems that happen in some of the cells. They can decide that those cells aren't allowed to continue to grow and divide and only focus on helping the good cells grow and divide. And so you don't know what's happening with the other 95% of the cells in the embryo. You only know about that biopsy. That is the definition of a screening test. That means we put this embryo in, we say, we think that this is a chromosomally normal boy. And then what's really important is that you know or don't know that it's a boy, but you think this is a chromosomally normal baby, and you need to talk to your OBGYN and maybe even a high-risk obstetrician about screening tests or diagnostic tests that should happen later in your pregnancy to confirm that this is a chromosomally normal pregnancy. So that's very scary and I think hard to digest. And let me just say, it's a really darn good screening test. So we're talking 99.x% specific and sensitive, but there is something in that less than 1% that is worth noting. And we can't promise you that your baby doesn't have Down syndrome or doesn't have a monosomy based on our biopsy. We can tell you it's screened normal. This is an excellent screening test. So just important to know that as well. In terms of outcomes, so I've talked a little bit about like normal. So I think, and again, this is PGTA specific because M and SR are a little bit rarer and I think more nuanced. But with PGTA, so you can get it screened euploid. Euploid is our medical term for normal number of chromosomes. You can get it screened aneuploid, and that means abnormal number of chromosomes. And there is some specificity usually in the reports about what is abnormal. So are we missing a 14 chromosome? Are we missing a 2? Do we have 2 extra copies of 18? Whatever. So you get some data there, and that is aneuploid. And then there is this category that is that's hard, for lack of a better word, that's called mosaic. And that means some of the 5 to 10 cells that you sent to this lab are normal, and some of the 5 to 10 cells that you sent the lab are abnormal. And that is something that we really don't know what to do with as reproductive endocrinologists. Like there's not an easy answer to that question because you don't know if the other 95% of the embryo is the same as the normal cells or if the other 95% of the embryo is the same as the abnormal cells. And so that is something that you should know could be a result that you get. I don't think it should make you decide to do or not do genetic testing, but you need to be aware that that's a possibility, and you need to know that if that's a possibility, you're going to have a hard conversation with your REI about what to do with those embryos. Typically, we say store and save all of your euploid embryos until you're done building your family. We say it is safe to discard your aneuploid embryos and not pay a storage fee for those and not hold on to those sort of emotionally as part of the like baggage of this process. And then honestly, at this point, like I tell patients, hold on to the mosaics. I don't know what to tell you to do with those. If that's all you have for transfer, we can have a conversation about it. But so much has changed since I entered medical school in the field of REI, and I'm like, not that old, that it's kind of incredible the potential for a mosaic embryo and what we could learn about it in the future. So I'm talking like not in 15 years when your baby is in high school. I'm talking like in 2 or 3 years we might know more about what to do with mosaic embryos. Important that you know that you could get that read. The other piece that's important to know that you could get on the result, which is super frustrating, is no read, which is like, we didn't get enough DNA, we can't really tell, oh dear. And that shouldn't happen that often. It should happen about 2 to 4% of the time. Some genetics labs quote as high as 5%. So you should not expect to have like 7 embryos and 5 of them are like, I don't know. That would be strange. But you should know that there's the potential that you do the biopsy, you don't have the genetics, and then you're having the conversation about, do we thaw and rebiopsy that embryo? Do we transfer it and just not know? What do we do? Okay, so those are the outcomes. Okay, I touched a little bit, my time is coming to an end. I touched a little bit about what do we do with abnormals and what do we do with mosaics. And let me just say, this is an incredibly personal decision. Patients have very strong feelings, both intellectually, emotionally, from a religious standpoint about what to do with embryos, right? I mean, that is heavy. And so you do whatever you want to with your embryos, okay? I mean, that is you and your partner, or you alone if you're unpartnered, or what, you make that decision. From an REI standpoint, I'll just tell you our general gestalt is you keep the normals, you discard, donate to science the abnormals, and then hang on to the mosaics. But just know that it is okay to hold on to abnormal embryos until you close that chapter. It is also okay to transfer abnormal embryos if you are fully educated, you've had the appropriate genetics consultation about that, and you are comfortable with the possibility of no pregnancy and miscarriage, or a child who is affected by a chromosomally related disease or disorder. So that is a difficult conversation, but one that you can have, and important to know. I just think from like a mutual decision-making standpoint, the transfer of chromosomally abnormal or mosaic embryos is possible. There are some special logistics, and you need to really make sure you're making an informed decision about it. It's not to be done lightly, but it's something that we're seeing. Okay, I've talked a lot, and I would love to turn it back over to Kristin, answer questions through the feed.
It's so nice to hear all this information. And I know that I'm not trying, but I think sometimes there is the sense of when you're in the medical office as the patient, like if there's intimidation of, people have like white lab coat syndrome, and there's just pressure. And sometimes, are you in a gown? I don't know. So I hope that even just being able to be at home in the comfort of your home and hearing this information related to genetic testing, you can do it in a sense that's way less emotional. I mean, let's be honest, infertility and emotions are like hand in hand. That's why I'm here. But when you can listen to this information from a much calmer sense, it might help you understand it and take it in and make the best decision for you. So I'm just so thankful that you are here with us tonight to share your knowledge, and everybody who's on this call tonight and everybody who's on the list will get access to the replay, so you can listen again if something clicks for you later. Because you did say, like, take notes. This is I took so many notes. Like, this is medical stuff. So, yeah, I was trying to fill some airwaves time so people could send in some questions. I don't know. Are you getting private ones?
I just got one.
Okay.
The question was, what percentage of patients do genetic testing? I think that's a great question. So it's crazy how sort of regionally specific that is, and how clinic specific that is. I will say in the mandated states, so some states have the incredible advantage of having all fertility care covered under all insurances, which is just amazing. So in those states, you might imagine like everybody does genetic testing. It's sort of like, part of the package, and you just sign up when you sign up for your IVF cycle. And you just do it because it might help and it doesn't hurt, and great. I think it also depends on sort of your patient profile in terms of cause of infertility. So when someone has something as simple as tubal factor infertility, but everything else looks fine. So a 29-year-old whose tubes don't work well, it feels less compelling to recommend genetic testing to a patient like that. And so clinics that see more patients of that profile probably do a lot less of it. So I think it's a hard question to answer. I would say within our clinic, and my partner's here with me, but within our clinic, I would say over the last year, we've seen a huge jump in the number of patients that have done it. And we're probably somewhere around 40-50%. Yeah. We're right on, 40 to 50%, I think, of our patients are doing the genetic testing now. Okay, I have another great question. is it more likely that you'll have an abnormality and therefore you do the follow-up testing after implantation? And no, I was not clear about that. So let me clarify. You as an IVF patient who does genetic testing are actually at decreased chance of having a genetic abnormality, like substantially decreased chance. The problem is because it's a screening test and we tested that embryo and that little bit of the embryo when it was 100 cells, and then we put it in the uterus and then it grows and becomes a baby. We just don't know with certainty that the cells that we got sample that full being as it develops further. So no, I would say you are at a decreased chance if you do genetic testing of having a genetic abnormality across the board. It's just that it's not a perfect test because it's screening. So we didn't get to sample every single cell in that embryo and say every single one of these is normal. And so that's why there's follow-up. That's why you might do cell-free DNA with your OB at 14 weeks, which is sort of standard of care. And that is another test that checks and says, yep, no extra chromosomes here. Yep, that's a girl. And then you kind of have sort of backup information. I just think it's important that patients understand it's not perfect, and you should still be a regular OBGYN patient. Like, you should go to your OB and you should be like, I did IVF and I did this genetic testing, but I still want my regular ultrasound, and I want you to look at the anatomy of my baby, and I want to make sure that the heart has 4 chambers, and I want to make sure that this baby has, normal kidneys. So it's not a panacea is the main point. Okay, great questions. So genetic testing for women under 35, I think specific to the patient, if there are other things going on, I think it's a personal decision. I talk to every single one of my patients about genetic testing. I think it depends on who you are, what your tolerance is for multiple embryo transfers, how strong you feel in terms of potential risk of miscarriage. So I mostly talk about like time to pregnancy is a little bit shorter if you do genetic testing. Live birth per embryo transfer goes up. So for patients who have had many miscarriages or 18 months of infertility and are just, they're just kind of losing their minds as people do, I say, yeah, like, why don't we genetically test your embryos? It'll help us pick which one to put in the first time around. And it might just like make your heart happier knowing that, it might just make you feel better. And so I think that's fine. I think what it does for us is much more important in an older age population, but not to be undermined or underscored less than 35. Importantly, low ovarian reserve in a woman who is young does not increase your risk of having a chromosomally abnormal embryo. So just because you have few eggs does not mean that those eggs are at higher risk of being abnormal if you're young. So I think what you should know about that is you're going to have more embryos to freeze and keep and hold on to if you don't genetically test them. You're going to be like, yeah, I have 10 embryos in the freezer, or I have 7, but you don't know the genetics of those embryos. You're going to be freezing fewer embryos or holding on to them and storing fewer if you genetically test them. I think if you have low ovarian reserve and you're worried about not getting many eggs at your retrieval, one thing I say is like, look, we might not have that many embryos to transfer. And so if we only have 3 embryos, do you want to know which of those 3, 1, 2, or all 3 is genetically normal or abnormal? Like, does that help you? I also think that when you get to a patient who has only 1 embryo at all on day 5, you don't lose much by not testing and just doing a transfer. Like, there are some logistics about finances, and I won't minimize those, but you have an embryo, you can transfer the embryo. You don't have to genetically test at that point if that feels like too much pressure or, there's too much stakeholding in that genetics. I hope that's all helpful. It's a lot. I mean, this is hard. This is like really, you take your patients and you kind of figure out where they are. You get to know them, right? You know your IVF doctor. You've done some other stuff by the time you get to this point, and then y'all like hold hands and kumbaya and figure out what the right decision is. But I hope that I'm getting to some of the questions.
The question too came up about increased chance of preeclampsia due to genetic testing.
Yeah. Great question. Okay, so this is super important. Obviously, so just for background, my husband is a maternal fetal medicine specialist. I think that's incredibly important because there's like a lot of pressure for me to not send him patients who will be unwell during their pregnancy, right? So he's like super not into twins. He doesn't want any preterm deliveries. So in the back of my mind always is like, if I go home and I tell Danny that that this is happening to my patient, is he going to blame me because of my intervention as a fertility specialist? So I'm thinking about this stuff all the time, just to give you background. That's my personal bias. What we know is that there might be some increased risk because you're biopsying that placenta of sort of poorer placentation, or we think that this might be the cause of preeclampsia. So yes, in PGT embryos, there was a recent study, and I hesitate to go into the specifics because I just never want to misquote the data, but there was a recent study that did suggest that PGT tested embryos put mothers at a higher risk of preeclampsia. That did not change baby coming home from the hospital, baby being like timing of delivery, mode of delivery. So there were lots of things that didn't change, but that is a hypertensive disorder of pregnancy. So what we know about women who do IVF in general, just as background to that, is they are at increased risk of lots of things in pregnancy that women who do not undergo IVF are at risk of. Those include gestational hypertension, preeclampsia, C-section, gestational diabetes. And when you look at why, it's not the infertility that's the problem, and it's probably not the IVF that's the problem. It's who your patients are that need the treatment that are the problem. So if you look at most IVF patients globally, they tend to be older, they tend to have other comorbidities. And so I'm not like saying this about any of y'all. I'm just saying if you look like at all of the people that need IVF, there is a higher pre-test probability, like you're coming in with some baggage that you carry with you into the pregnancy. So individually, like I look at my patient and I'm like, you don't have any blood pressure problems, you are all of these things that make you at low risk, and this IVF should not in and of itself increase your chance of those things. Specifically, the PGT can increase the risk of preeclampsia, but does not change outcomes for the baby. And there's no data on like eclampsia or the really rare things. That's been one study. I hesitate to make sweeping remarks like that, but I read it and pay attention to it, and worth mentioning.
I would like to ask a question that I get, actually a lot of my clients have asked about testing is, are there choices where you do the testing? Like, because pricing seems to vary too.
Yeah. Oh, great question. Okay. So, yes, choices. Personal patient choice, not usually. Usually your clinic has an established relationship within a genetics lab. And the reason that they have established that relationship is nuanced. So the pricing strata for this type of stuff is hard. Some do it by embryo. Some do it, they batch it. So you get one price for up to 8 embryos, and then every embryo after that is an extra whatever. So usually the clinics have kind of looked at their patients. They've said, this is how many of our patients are doing genetic testing. This is how many embryos we're typically sending per patient. This is what makes sense for our patients monetarily as a group. So I will say, I mean, to my knowledge, most clinics already have that relationship worked out. And so the onus is not on you as the patient to figure out where should my genetic testing happen. I think asking your doctor where your genetic testing is going to happen and like what the platform is and how many of them are no read and, you know, like, is it a legitimate place? And obviously none of us are like trying to do illegitimate work, but just asking those questions is totally fair. But usually that's already been worked out. And typically it's because it's whatever is most financially reasonable for that clinic's population and patients, because this is an added cost. The biopsy can be an added cost, and then the actual testing can be an added cost. So great question. So yes, if you are a person who like did IVF whenever and you didn't test your embryos, but you would like to now, what should you consider? So you should consider the age that the female was when the embryos were made. So we talk about age a lot in this field, but your risk of aneuploidy is the same for that embryo at the age of the mom when the embryo was made. So like if you were 28 when you made your embryos and now you're 37, your risk of aneuploidy is that of a 28-year-old, because that's how old the eggs were when they were made. You can absolutely thaw, biopsy, and genetically test embryos that were previously frozen. That is totally possible. What are the risks of it? Some embryos might not survive the thaw. So that's when the quality of the embryo is determined by the lab. Like, do I have a bunch of grade 1 embryos or 4AAs or whatever that will survive the thaw, can be biopsied, and can be refrozen? Or does my lab feel like some of my embryos could be thawed, biopsied, and refrozen, and for some that might not be a good idea because the embryo might not make it through that process. So it's not totally benign to thaw, biopsy, and refreeze an embryo. It's certainly the right answer for some patients and can be done safely, I would say, depending on the embryo grade in general.
Just thinking, you know, like you mentioned, if storage, how many you have in storage, if you reduce the number, it may help the decision making as well for the patient from an ethically charged standpoint too. It's just another thought.
Thank you for that. Yes, so it's really important. I did mention you might have fewer embryos to freeze. I think it weighs heavily on people, this supernumerary embryo, like I want 3 kids, I have 7 embryos, what I do. So you might have fewer embryos that you freeze because you have the genetics on them. You also might have a reduced storage fee, which is like a terribly cynical way to think about making this decision, but money is real. And so if you are paying by the embryo for storage fees, or you're paying by like a cohort of embryos, you will have a reduced number of normal if you do the genetic testing. So you will be reducing the number generally of embryos that you store. Thanks for having me. Thanks for doing this with us, and looking forward to another one.
Yeah, awesome. Well, I'm going to then take it over and talk about, for anybody who got the worksheet and got my little preview, I'm going to be sharing. So what we do every time is we start with the guest expert to talk about the medical side of infertility. And then me as the infertility coach, I like to talk about and focus on the emotional side. So I am here to share. Now, it's hard to specifically talk about genetic testing because that is a piece, but I decided to really more talk about the things that can help when you've maybe had a failed cycle or transfer, because that also might be some of the reasons why, you know, you might have had a loss, and that might be why you're considering genetic testing as opposed to necessarily first timer. So I kind of wanted to speak on that front. So the worksheet says that I really wanted to share what I wish people had said to me. And I'm sharing that with you in case you needed to hear it. No matter where you are in the stage of infertility, I think all of this emotional stuff matters. And sometimes just hearing what I'm about to say might be just the words you needed to hear. And if you're like me, when so my first cycle didn't work. I did a transfer of 2 embryos, fresh transfer, and it didn't work. And I was devastated. I felt like a failure, and I was afraid I wasn't worthy of love from my husband because I couldn't make him he was a dad, but I couldn't make him another dad. I couldn't grow our family. And I was just really down the dumps. I thought because it didn't work, it was never going to work, because I really thought that just doing IVF and doing the medicine, that was going to be the answer. So if you're like me, then you know that maybe you had some of those same feelings and doubts, or going through that right now. There were days where I felt like going through normal everyday life felt impossible. And I was mad that the people who I did open up to moved on with their life. And I just felt like my life was on hold. So I'm guessing that you might have experienced some of that yourself. And so what I wish somebody had told me all at once was that all of my feelings were absolutely normal, that they did not make me a bad person, to be jealous of pregnancy announcements, to be fearful of moving forward or trying again, to be feeling like it was never going to happen. That was all normal. I wish somebody told me that it was okay to take time, that no decision had to be made right then and there, from getting the call that the beta numbers were, 0, that it is okay to take time and to think about it, to feel those feelings, to go through that grief of it not working, and then make a better decision about what to do moving forward. Because every one of us is in a different situation on what happens after getting some bad news. I wish somebody told me that it failed, the transfer failed, but I didn't fail, that I wasn't a failure. And now that I'm as far along as I am right now, and one of the things I work on with my clients is to talk about actually choosing the word fail and maybe not using it. That sometimes, this is a little bit of science. I see the cute onesies that say made with lots of love and a little bit of science. And a lot of science is experiments. And sometimes while the doctors know what they're doing, it can make you feel better to think about it more as you're going through this experiment to see how your body responds, how your body reacts to the protocol that you were given. And if it doesn't work, that doesn't mean it's a failure. It just means you might need to tweak something and try again and try something different. But I felt like I was the failure. And so I try and work on the words we use, and also realizing that I wasn't the failure. Just that transfer did not work. I wish somebody told me that I was worthy of love, whether I was a mother or not. I think every one of us who's here or watching this right now, you're probably wishing you were a mom years ago, and you're watching everybody around you get pregnant easily, and you feel like you're getting farther and farther away from the mom club, and it's feeling like you're not going to belong. And I'm just here to tell you that you belong, whether you have the title of mom or not. And I wish somebody told me that it does get easier, that over time it gets a little bit easier day by day. So that's all the stuff that I wish somebody had told me. And I sort of started talking about what you can learn from a failed cycle. Because again, what I work on with clients is how to look at it as not taking away all of the joy and sucking the joy out of your life. I had a really different experience between my first cycle and my second cycle because of all the work I did on my mindset. And that's what I work on with clients right now. But just because it didn't work doesn't mean it can't work. So what you learn is how your body responds. And that is one on the doctor side. Your doctor will say, this looked good, this looked good. They might say, we could make improvements or changes here. They might say, we need to do exactly the same thing. This just wasn't the cycle. I always say that every cycle is different. And again, I'm not the doctor, but I say that every cycle is different. And so it could work again. Just because it didn't work the first time doesn't mean it can't work again. I think our instinct is wanting to change everything. I mean, I can't tell you how many people call and they're like, I need to change my doctor. What practice do you recommend? And it's like, breathe. Maybe changing the doctor is the answer, but it might not be the answer. Don't be so quick to change all of the things. Have a little bit of faith, but let's also take a breath, calm down, and evaluate the situation. But there are different protocols. Dr. Likes talked about in a different replay or a different workshop that we did talking about protocols. So sometimes that's what your doctor is going to say based on you and how your body responded. Sometimes they're not going to change anything. But I think being prepared to hear that can help, because so many women think it failed. What are we going to do differently this time? One of the things that you also learn is how your body reacts to the hormones and the emotions and the impact on your the headaches, the tiredness, the bloating, the uncontrollable crying, or, just being hormonal. We all respond to some things are very common, but some things might be different to you. And I think it's really interesting to take note of how you do respond and react to it, so that when you are ready to try again, you're prepared for all of those parts, as well as the ultrasound, as well as the monitoring appointments and doing the shots at night. You learn about your resiliency and your strength, because if it failed or it didn't work, that is what you didn't want, right? That's like the worst case scenario. That's what you didn't want. And you're still alive, you're still here, you're still breathing. That means you still have another chance and you still have an opportunity. You can go through really hard things. I heard somebody tell me this the other day, and it was so interesting. But when you are in a situation and you still are thinking about other people. So like when my first transfer didn't work, I was so worried about telling my parents, because they were supportive and I knew they wanted it as much as we wanted it. And having to tell your parents, okay. I didn't want to tell my parents. Or my doctor, I didn't want to be like the fail, right? Okay. What I heard was that if you are still thinking about other people, it means you still have gas in your tank. It means that you still have enough strength to move forward, because people who don't can only look inward and only look at themselves. So if you're in a position where life is really hard and tough, but you're still considering other people around you, it means that you have so much more strength inside you than you know and that you're aware of. And so a lot of people that I work with are in that position where they talk to me and they say that they're worried about everybody else. And I'm like, just so happy to hear that, which is why I get so emotional, because it just really means that they can keep going and they don't have to give up. Clearly, finances aside and all of that, there's so much to the equation. But hearing that story, that if you can think of other people when you're in a really down in the dumps place, it means that you do have a lot more energy and fight in you. And I thought that was a really good thing to look at. You learn how to ask for help, because when you go through this process, you realize some days you're brought down to a point where you have to ask for help. You have to ask for help maybe at work because you don't want to deal with that coworker who's pregnant or complains about her kids. You might have to ask for help because you're just feeling really exhausted and you can't make dinner. And so you've got to lean on your partner or somebody else to help with dinner. And all of those things at the end, they're going to help you when you're pregnant and when you're a new mom. And so again, the words you use and the way you look at it are choices. And so when you can look at this experience of getting through the hard point when it didn't go well, it didn't work out as you thought, you can look at it as a way to say, okay, how can this plan me and prepare me for what is coming next, which is when you will be pregnant and when you are a mom. And also the biggest thing is that it's not just about the medicine. I'm such a believer that like it's an equation, like it's made with love and science. And I wish, also, and mindset and heart and money, so there's missing a few things there. But I went to the doctors thinking that was the answer and I didn't have to do anything. All I had to do was do shots and show up for appointments. And as much as I love Dr. Von Hofe and the team that helped me, it's like, I really do believe that there's so much to it, and that's a piece of it. And you have the control to make the experience better for you and less of like an emotional drain. And so the tools that you will use to pick yourself up are the tools that will help you get through and try again and be strong enough and be a fighter. Okay. And then why you shouldn't give up. Well, hopefully my story can be inspiration, because the first round didn't work, but the second round did. And we did do genetic testing. So clearly I'm a big supporter of that. So just because it didn't work the first time does not mean it won't work or it can't work. I also really believe that if the dream is in you, it's for you, and that you will find a way and you will make it. And it's just okay to take time. It's okay to take a break. It's okay to evaluate your situation. There's nothing, again, I know that you wanted this baby years ago, months ago, as soon as you want to be pregnant. Actually, Dr. Likes, the interview you did, she said this, and I was like, yes, as soon as you want to be pregnant, you already want to be pregnant. When you're ready, you're like, okay, bring the baby. So then to have to go through infertility, I know some of you are waiting years. So it is hard, but sometimes taking 2 months, sometimes taking the time to do the genetic testing and doing a frozen transfer is exactly what you need for the long-term goal. And so I really believe in the heat of it, when you are making a decision, to keep your eye on the end game and on the end goal and what you want. And don't make a decision for the speed or the timing. Make a decision that's going to make it more likely to succeed. I did want to just say that anybody who is looking for a doctor and is interested, you would be in wonderful hands with either Dr. Von Hofe or Dr. Likes. And the fact that they're both here giving up their nights and their free time, spending time, there's time spent ahead of this. They're not just here for the hour. That shows a lot to me. And as a patient, I care so much about that stuff. So your actions speak way louder than some infomercial or social media ad. So I just wanted to point that out, that anybody would be in good hands with either one of you.
Thank you for saying that, and thanks for doing what you're doing.
Yeah.
We'll have more.
All right. Yes.
All right.
Okay. Bye, guys.